Hello, and welcome back to another chapter of Advanced Pharmacology. Today we'll be discussing chapter 43, Drugs for Angina Pectoris. Angina pectoris is defined as sudden pain beneath the sternum, often radiating to the left shoulder, left arm, and the jaw. Anginal pain is precipitated when the oxygen supply to the heart is insufficient to meet oxygen demand. Most often, angina occurs secondary to atherosclerosis of the coronary arteries, so angina should be seen as a symptom of a disease and not as a disease in its own right. In the United States, more than 10 million people have chronic stable angina, and about half a million people develop new cases annually. Drug therapy of angina has two major goals. The first, the prevention of a myocardial infarction and death, and the second, prevention of myocardial ischemia and anginal pain. The two types of drugs are employed to decrease the risk of MI and death: cholesterol-lowering drugs and antiplatelet drugs. These agents are discussed in chapter 42 and 44 respectively. In this chapter, we're going to focus on the anti-anginal drugs, so drugs that help prevent myocardial ischemia and anginal pain. There are three main families of anti-anginal agents: organic nitrates, so your nitroglycerin, your beta blockers, such as your metoprolol, and calcium channel blockers, such as your verapamil. In addition, a fourth agent, ranolazine, can be combined with these drugs to help supplement their effects. Most of this chapter focuses on the organic nitrates. Beta blockers and calcium channel blockers are discussed at length in prior chapters, so consideration here is limited to their use only in angina treatment. So let's start off with the determinants of cardiac oxygen demand and its oxygen supply. Before discussing angina, we need to review the major factors that determine cardiac oxygen demand and supply. So, starting off with the demand, the principal determinants of cardiac oxygen demand are heart rate, myocardial contractility, and most important, intramyocardial wall tension. Wall tension is determined by two factors: your cardiac preload and cardiac afterload. Preload and afterload again were defined in chapter 34. However, in summary, cardiac oxygen demand is determined by the heart rate, the contractility, preload, and afterload. Drugs that reduce these factors reduce oxygen demand, which brings us to the opposite side of oxygen supply. Cardiac oxygen supply is determined by myocardial blood flow. Under resting conditions, the heart extracts nearly all of the oxygen delivered to it by the coronary vessels. Therefore, the only way to accommodate an increase in oxygen demand is to increase its blood flow. When oxygen demand is increased, coronary arterioles dilate. The resultant decrease in vascular resistance allows blood flow to increase. During exertion, however, coronary blood flow increases fourfold to fivefold. It's important to note that the myocardial perfusion takes place only during diastole. Perfusion does not take place during systole, because the vessels that supply the myocardium are squeezed shut when the myocardium contracts. So let's figure out the pathophysiology of angina so that we can provide a proper treatment strategy. Angina pectoris has three forms: chronic stable angina, which is your exertional angina; variant angina, which is that transmetal or vasospastic angina; and then we have the unstable angina. Our focus is on stable and the variant. Consideration of unstable angina is discussed in the acute care chapter at the end of your text. So, chronic stable angina, your exertional angina. The pathophysiology. Stable angina is triggered most often by an increase in physical activity, emotional excitement, large meals, or cold exposure that all may precipitate an attack. Because stable angina usually occurs in response to strain, this condition is also known as exertional angina or angina of effort. The underlying cause of exertional angina is coronary artery disease, a condition characterized by the deposition of fatty plaque in the arterial wall. If an artery is only partially blocked by plaque, blood flow will be reduced and angina pectoris will result. However, if complete vessel blockage occurs, blood flow will stop and a myocardial infarct or heart attack will result. The effect of CAD, or coronary artery disease, on the balance between a myocardial oxygen demand and oxygen supply will be shown in Figure 43.1. In both the healthy heart and the heart with CAD, oxygen supply and oxygen demand are imbalanced during rest. In the presence of coronary artery disease, resting oxygen demand is met through the dilation of the arterioles, distal to the partial occlusion. This dilation reduces resistance to blood flow, compensating for their increase in resistance created by the plaque. So here's a good spot to hit pause if you need a visual review of the effects of exertion on the balance between the oxygen supply and oxygen demand in a healthy heart. The picture here is very difficult or different during exertion. In the healthy heart, as cardiac oxygen demand rises, coronary arteries dilate, causing flow of blood to increase. The increase keeps oxygen supply in balance with oxygen demand. In contrast, in a patient that has coronary artery disease, arterioles in the affected region are already fully dilated during rest. Thus, when exertion occurs, there's no way for the increase in the blood flow to compensate for the increase in oxygen demand. The resultant imbalance between the oxygen supply and the oxygen demand is what causes that anginal pain. So, our treatment strategy. The goal of anti-anginal therapy is to reduce the intensity and frequency of anginal attacks. Because anginal pain results from the imbalance between oxygen supply and oxygen demand, logic dictates two possible remedies. The first being an increase in cardiac oxygen supply. The second, a decrease of oxygen demand. Because the underlying cause of stable angina is the occlusion of the coronary arteries, there is little we can do to increase cardiac oxygen supply. Therefore, the first remedy is not a real option. Consequentially, all we really can do is decrease cardiac oxygen demand. As discussed earlier, oxygen demand can be reduced with drugs that decrease the heart rate, contractility, afterload, and preload. So, our overview of therapeutic agents. Stable angina can be treated with three main types of drugs. Again, the organic nitrates, beta blockers, and calcium channel blockers. As noted previously, ranolazine can be combined with these drugs for additional benefit. All four groups relieve the pain of stable angina, primarily by decreasing that cardiac oxygen demand. Please note that the drugs only provide symptomatic relief. They do not affect the underlying pathology. To reduce the risk of a myocardial infarction, all patients with known coronary artery disease should receive an antiplatelet drug, such as aspirin, unless it's contraindicated. Other measures to reduce the risk for infarction are discussed later in this section. And the section is called Drugs Used to Prevent Myocardial Infarction and Death. So, the mechanism of anti-anginal action. It's an excellent spot here to look at this table and review different medications, such as your nitrates, beta blockers, calcium channel blockers, and that ranolazine that we were talking about. There also is the non-drug therapy. Patients should attempt to avoid factors that can precipitate angina. These would include overexertion, heavy meals, emotional stress, or exposure to cold. Risk factors for stable angina should be corrected. Important among these are smoking, hypertension, hyperlipidemia, and a sedentary lifestyle. Patients should be strongly encouraged to quit smoking. Patients with a sedentary lifestyle should be encouraged to establish a regular program of aerobic exercise. Hypertension and hyperlipidemia are major risk factors and should be treated. These disorders are discussed in Chapter 39 and 42 respectively. That brings us to the variant angina, or the Prinzmetal angina, also known as vasospastic angina. So, three different ways to see the same thing. Its pathophysiology. The variant angina is caused by a coronary artery spasm, which restricts blood flow to the myocardium. Therefore, as in stable angina, pain is secondary to insufficient oxygenation of the heart. In contrast to stable angina, whose symptoms occur primarily at times of exertion, variant angina can produce pain at any time, even during rest and sleep. Frequently, variant angina occurs in conjunction with stable angina. The treatment and strategy for treatment. The goal is to reduce the incidence or the severity of these spasm attacks. In contrast to stable angina, which is treated primarily by reducing that oxygen demand, variant angina is treated by increasing cardiac oxygen supply. This makes sense in that the pain is caused by the reduction in oxygen supply, rather than by an increase of the demand. Oxygen supply is increased with vasodilators, which prevent or relieve coronary artery spasms. The overview of the therapeutic agents. Vasospastic angina is treated with two groups of medications, calcium channel blockers and organic nitrates, both of which relax coronary artery spasms. Beta blockers and ranolazine, which are effective in stable angina, are not effective in variant angina. As with stable angina, therapy is symptomatic only. Drugs do not alter the underlying pathology of the issue. So, speaking on organic nitrates. The organic nitrates are the oldest and most frequently used anti-anginal drug. These agents relieve angina by causing vasodilation. Nitroglycerin, the most familiar organic nitrate, will serve as the prototype for discussion. So, nitroglycerin. Nitroglycerin has been used to treat angina since 1879. The drug is effective and fast-acting, and it's inexpensive. Despite availability of newer anti-anginal agents, nitroglycerin remains the drug of choice for relieving an acute anginal attack. Vasodilator actions. Nitroglycerin acts directly on vascular smooth muscle, or VSM, to promote vasodilation. At usual therapeutic doses, the drug acts primarily on veins. Dilation of arterioles is only modest. The biochemical events that lead to the vasodilation begin with uptake of nitrate by your VSM, followed by conversion of nitrate to its active form, nitric oxide. As indicated, conversion requires the presence of sulfhydryl groups. Nitric oxide then activates guanylyl cyclase, an enzyme that catalyzes the formation of cyclic guanosine monophosphate, which is your cGMP. Through a series of reactions, the elevation of your cGMP leads to the dephosphorylation of light chain myosin in VSM. Keep in mind that in all muscles, phosphorylated myosin interacts with actin to produce contraction. So, as a result of the dephosphorylation, myosin is unable to interact with the actin, and therefore your VSM relaxes, causing vasodilation. For our purposes, the most important aspect of the sequence is the conversion of the nitrate to its active form, nitric oxide, in the presence of a sulfhydryl source. So its mechanism of anti-anginal effects. So on stable angina, nitroglycerin decreases the pain of exertional angina primarily by decreasing cardiac oxygen demand. Oxygen demand is decreased as follows. By dilating veins, nitroglycerin decreases venous return to the heart and therefore decreases ventricular filling. The result decreases in wall tension, decreases oxygen demand. In patients with stable angina, nitroglycerin does not appear to increase blood flow to ischemic areas of the heart. The statement is based on two observations. The first being, nitroglycerin does not dilate atherosclerotic coronary arteries. Second, when nitroglycerin is injected directly into the coronary arteries during an anginal attack, it does not relieve pain. Both observations suggest that pain relief results from effects of nitroglycerin on peripheral blood vessels, not from effects on the coronary blood flow. Variant angina. In patients with variant angina, nitroglycerin acts by relaxing or preventing spasm in coronary arteries. Therefore, the drug increases oxygen supply. It does not reduce the oxygen demand. So, let's talk about the pharmacokinetics. Nitroglycerin is a highly lipid soluble and crosses membranes with ease. Because of this property, nitroglycerin can be administered by uncommon routes. The primary in hospital setting is the sublingual route. However, there is also the buccal and transdermal, as well as by more conventional routes, oral and intravenous. Again, in the hospital setting, you'll most likely either give it in the sublingual or in a transdermal patch. However, if you're working in an intensive care unit or a step-down unit, you may give it IV. Its metabolism, nitroglycerin, undergoes rapid inactivation by hepatic enzymes, the organic nitrate reductases. As a result, the drug has a plasma half-life of only 5 to 7 minutes. When nitroglycerin is administered orally, most of each dose is actually destroyed on its first pass through the liver. So, nitroglycerin does have adverse effects, which are generally well tolerated. However, the principal adverse effect is headache, hypotension, and tachycardia. Occurs secondary due to the vasodilation. Headache. The initial therapy can produce a severe headache. This response diminishes over the first few weeks of treatment. In the meantime, headache can be reduced with aspirin, Tylenol, or some other mild analgesic. Orthostatic hypotension. Relaxation of VSM causes blood to pool in veins. When the patient assumes an erect posture, pooling decreases venous return to the heart, which reduces cardiac output, causing blood pressure to fall. Symptoms of orthostatic hypotension include lightheadedness and dizziness. Patients should be instructed to sit or lie down if these occur. Lying with the feet elevated promotes venous return and can help restore blood pressure. Reflex tachycardia. Nitroglycerin lowers blood pressure, primarily by decreasing venous return and partly by dilating arterioles. By lowering blood pressure, the drug can activate the baroreceptor reflex, causing sympathetic stimulation of the heart. The resultant increase in both heart rate and contractile force increases cardiac oxygen demand, which negates the benefit of therapy. Pre-treatment with a beta blocker or verapamil, a calcium channel blocker, can prevent sympathetic cardiac stimulation. Drug interactions. Because hypotensive drugs, such as nitroglycerin, can intensify the effects of other hypotensive agents, consequently, care should be exercised when nitroglycerin is used concurrently, especially with beta blockers, calcium channel blockers, diuretics, and all other drugs that could potentially lower your blood pressure, including the inhibitors of phosphodiesterases type 5 or PDE5s. Also, patients should be advised to avoid alcohol. So speaking on beta blockers, verapamil and diltiazem specifically, these drugs can suppress nitroglycerin-induced tachycardia. Beta blockers do so by preventing sympathetic activation of the beta-1 adrenergic receptors on the heart. Verapamil and diltiazem prevent tachycardia through direct suppression of pacemaker activity in the sinoatrial node. Tolerance. Tolerance to nitroglycerin-induced vasodilation can develop rapidly, over the course of a single day even. One possible mechanism is the depletion of your sulfhydryl groups in your VSM. In the absence of sulfhydryl groups, nitroglycerin cannot convert to nitric oxide, its active form. Another possible mechanism is reversible oxidative injury to the mitochondrial aldehyde dehydrogenase, an enzyme needed to convert nitroglycerin again into nitric oxide. Patients who develop tolerance to nitroglycerin display cross-tolerance to all other nitrates and vice versa. Development of tolerance is most likely with high-dose therapy and uninterrupted therapy. To prevent tolerance, nitroglycerin and other nitrates should be used in the lowest effective dosage. Long-acting formulas should be used on an intermittent schedule that allows for at least 8 drug-free hours every day, usually during the night. If pain occurs during the nitrate-free interval, it can be managed with sparing use of a short-acting nitrate, or by adding a beta blocker or calcium channel blocker to the regimen. Tolerance can be reversed by withholding nitrates for a short time. Its preparation and route of administration. Again, because nitroglycerin is available in several formulas for administration by several different routes, this proliferation of dosages forms reflects of efforts to delay hepatic metabolism and prolong therapeutic effects. All nitroglycerin preparations produce qualitative similar responses. Differences relate only to the onset and the duration of action. With two preparations, effects can begin within minutes, 1 to 5 minutes, and then diminish in less than an hour. With three others, effects begin a little slower but can last several hours. Only one preparation, the sublingual isorzobide dinitrate tablets, has both a rapid onset and a long duration. So here at this table, it's an excellent spot to hit pause so you can see the different forms of the medication and how to best prescribe, I guess, in a sense, whether you need something that's short-term or short-acting, long-acting, and how quickly the onset would be. Application of specific preparations are based again on their time course. Preparations with a rapid onset are employed to terminate an ongoing anginal attack. When used for this purpose, rapid-acting preparations are administered as soon as pain begins. Rapid-acting preparations can also be used for acute prophylaxis of angina. For this purpose, they are taken just before anticipated exertion. Your long-acting preparations are used to provide sustained protection against anginal attacks. To provide protection, they are administered on a fixed schedule. Trade names and dosages for nitroglycerin preparations here are in the following table. Again, it's a good spot to hit pause if you're unfamiliar with the different trade names and their dosages. So, let's start with sublingual tablets. When administered sublingually, nitroglycerin is absorbed directly through the oral mucosa and into the bloodstream. Therefore, unlike orally administered drugs, which must pass through the liver on their way to the systemic circulation, sublingual nitroglycerin bypasses the liver and therefore temporarily avoids an activation. Because the liver is bypassed, sublingual doses can be low, between 0.3 and 0.6 milligrams. These doses are about 10 times lower than those required when nitroglycerin is dosed orally. Effects of sublingual nitroglycerin begin rapidly in 1 to 3 minutes and can persist for up to an hour. Because sublingual administration works fast, this route is ideal, especially for terminating an ongoing attack. Short-term prophylaxis when exertion is anticipated. To terminate an acute anginal attack, sublingual nitroglycerin should be administered as soon as the pain begins. Administration should not be delayed until the pain becomes severe. According to guidelines, if pain is not relieved in 5 minutes, the patient should call 911 or report to an emergency department, because anginal pain that does not respond to nitroglycerin may indicate a myocardial infarct. While awaiting emergency care, the patient can take one more tablet and then a third tablet 5 minutes later. So there is patient education, especially regarding sublingual drug administration. Sublingual administration is unfamiliar to most patients. Accordingly, education is needed. The patient should be instructed to place the tablet under their tongue and leave it there while it dissolves. Nitroglycerin tablets formulated for sublingual use are ineffective if they are swallowed. To ensure good stability, the tablets should be stored moisture-free at room temperature in their original container, which should be closed tightly after each use. Your sustained-release oral capsules. Sustained-release oral capsules are intended for long-term prophylaxis only. These formulations cannot act fast enough to terminate an ongoing anginal attack. Your sustained-release capsules contain a large dose of nitroglycerin that is slowly absorbed across the GI tract or GI wall. In theory, doses are large enough so that amounts of nitroglycerin sufficient to produce a therapeutic response will survive the passage through the liver. Because they produce a sustained blood level of nitroglycerin, these formulations can cause tolerance. To reduce that risk for tolerance, these products should be taken only once or twice daily. Your transdermal delivery system. Your nitroglycerin patches contain a reservoir from which nitroglycerin is slowly released. After release, the drug is absorbed through the skin and then into the blood. The rate of release is constant and, depending on the patch used, can range from 0.1 to 0.8 milligrams per hour. Its effects begin within 30 to 60 minutes and can persist as long as the patch remains in place, so up to 14 hours. Patches are applied once daily to a hairless area of the skin. The site should be rotated to avoid local irritation. Tolerance develops if the patches are used continuously, so 24 hours a day. Accordingly, a daily patch-free interval of 10 to 12 hours is recommended. This can be accomplished by applying a new patch each morning, leaving it in place for 12 to 14 hours, and then removing it in the evening. Because of their long duration, patches are well suited for sustained prophylaxis. Because patches have a delayed onset, they cannot be used to abort an ongoing attack. Translingual spray. Nitroglycerin can be delivered to the oral mucosa using a metered dose spray device. Each activation delivers a 0.4 milligram dose. Indications for nitroglycerin spray are the same as for sublingual tablets: suppression of an acute anginal attack, and the prophylaxis of angina when exertion is anticipated. As with the sublingual tablets, no more than 3 doses should be administered within a 15-minute interval. Your topical nitroglycerin ointment is used for sustained protection against anginal attacks. The ointment is applied to the skin of the chest, back, abdomen, or the anterior thigh. Because your nitroglycerin acts primarily by dilating peripheral veins, there is no mechanistic advantage to applying nitroglycerin directly over the heart. After topical application, nitroglycerin is absorbed through the skin and then into the blood. Its effects can begin in 20 to 60 minutes and persist up to 12 hours. This ointment is dispersed from a tube, and the length of the ribbon squeezed from the tube determines the dose. 1 inch contains about 15 milligrams of nitroglycerin. The usual adult dosage is 1 to 2 inches applied every 4 to 6 hours. The ointment should be spread over an area at least 2.5 inches by 3.5 inches and then covered with a plastic wrap. Sites of application should be rotated to minimize skin irritation, and as with other long-acting formulas, uninterrupted use can cause tolerance. So, speaking on discontinuing nitroglycerin, long-acting preparations, again, the transdermal patches, topical ointments, and sustained-release oral tablets, should be discontinued slowly. If they are withdrawn abruptly, vasospasms can result. So, the summary of therapeutic use. In your acute therapy of an angina, for acute treatment of angina, nitroglycerin is administered in sublingual tablets and translingual spray. Both formulas can be used to abort an ongoing anginal attack and to provide the prophylaxis in anticipation of exertion. However, in your sustained therapy of angina, for the sustained prophylaxis against angina, nitroglycerin is administered in the following formulas: your transdermal patch, your topical ointment, and your sustained-release oral capsules. That brings us to isorzabide, the mononitrate, and isorzabide dinitrate. Both of these drugs have pharmacologic actions identical to those of nitroglycerin. Both drugs are used for angina, and both are taken orally, and both produce headaches, hypotension, and reflex tachycardia. The differences between them relate only to the route of administration and the time course of action. Time course determines whether the particular drug or dosage form will be used for acute therapy, sustained prophylaxis, or both. As with nitroglycerin, tolerance can develop to long-acting preparations. To avoid tolerance, the dosing schedule for long-term and long-acting preparations should allow for at least a 12-hour free day. Time courses are shown in the table 43.2. Your trade names and dosages are shown in table 43.3. A fixed combination of isorzabide dinitrates plus hydralazine is discussed in chapter 40. Which brings us to the beta blockers. Beta blockers, propranolol and metoprolol, are the first-line drugs for angina of effort, but are not effective against vasospastic angina. When administered on a fixed schedule, beta blockers can provide sustained protection against effort-induced anginal pain. Exercise tolerance is increased and the frequency and intensity of anginal attacks are lowered. All of the beta blockers appear equally effective. In addition to reducing anginal pain, beta blockers decrease the risk for death, especially in patients with a prior MI. Beta blockers reduce anginal pain primarily by decreasing cardiac oxygen demand, principally through the blockade of beta-1 receptors in the heart, which decreases heart rate and contractility. Beta blockers reduce oxygen demand further by causing a modest reduction in arterial pressure, that afterload. In addition to decreasing oxygen demand, beta blockers help increase oxygen supply. By slowing the heart rate, they increase time in diastole and thereby increase the time during which blood flows through myocardial vessels. In patients taking vasodilators, such as your nitroglycerin, beta blockers provide the additional benefit of blunting reflex tachycardia. For the treatment of stable angina, dosage should be low initially and then gradually increase. The dosing goal is to reduce resting heart rate to 50 to 60 beats per minute and limit exertional heart rate to about 100 beats per minute. Beta blockers should be withdrawn abruptly because doing so can increase the incidence and intensity of anginal attacks and may even precipitate a myocardial attack. Beta blockers can produce a variety of adverse effects. A blockade of cardiac beta receptors can produce bradycardia, a decreased atrioventricular conduction, and reduction of contractility. So, consequently, beta blockers should not be used by patients who have sick sinus syndrome, heart failure, or any type of second degree or third degree AV block. Blockade of beta 2 receptors in the lung can promote bronchoconstriction. Accordingly, beta blockers should be used with caution by patients who have asthma. If an asthmatic individual absolutely must use a beta blocker, a beta 1 selective agent such as metoprolol should be chosen. Beta blockers can mask signs of hypoglycemia and therefore must be used with caution in patients who have diabetes. Rarely, these drugs cause adverse central nervous system effects, which include insomnia, depression, and bizarre dreams. The basic pharmacology of beta blockers is discussed in Chapter 14. Which brings us to calcium channel blockers. The calcium channel blockers used most frequently are verapamil, diltiazem, and nifedipine. Accordingly, our discussion focuses on these three drugs. All three can block calcium channels in the VSM, primarily in arterioles. The result is arteriolar dilation and the reduction of the peripheral resistance, again, your afterload. In addition, all three can relax coronary vasospasm. Verapamil and diltiazem also block calcium channels in the heart and can thereby decrease your heart rate, your AV conduction, and their contractility. Your calcium channel blockers are used to treat both stable and variant angina. In variant angina, these drugs promote relaxation of coronary artery spasms, increasing cardiac oxygen supply. In stable angina, they promote the relaxation of the peripheral arterioles. The resultant decrease in afterload reduces cardiac oxygen demand. Verapamil and diltiazem can produce modest additional reductions in oxygen demand by suppressing the heart rate and the contractility. The major adverse effects of calcium channel blockers are cardiovascular. The dilation of peripheral arterioles lowers blood pressure and can therefore induce reflex tachycardia. This reaction is greatest with nifedipine and minimal with verapamil and diltiazem. Because of their suppressant effects on the heart, verapamil and diltiazem must be used cautiously in patients taking beta blockers and in patients with bradycardia, heart failure, and AV blocks. Those precautions do not apply to nifedipine or any other dihydropyridines. Again, the basic pharmacology of calcium channel blockers was discussed in Chapter 37, which takes us to ranulazine, its action and therapeutic use. Ranulazine, also known as Ranexa, represents the first new class of anti-anginal agents to be approved in more than 25 years. In clinical trials, the drug reduced the number of angina episodes per week and increased exercise tolerance. However, these benefits were modest and were smaller in women than in men. Unlike most other anti-anginal drugs, ranulazine does not reduce heart rate, blood pressure, or vascular resistance. However, it can prolong the QT interval and is subject to multiple drug interactions. Ranulazine works by reducing the accumulation of sodium and calcium in myocardial cells, which might help the myocardium use energy more efficiently. However, the exact mechanism of action is still unknown. Despite limited efficacy, many drug interactions, and the risk for dysrhythmias, ranulazine is now approved as a first-line drug for angina. It may be combined with nitrates, beta blockers, amlodipine, and other drugs used for angina treatment. So its pharmacokinetics. Absorption from the GI tract is highly variable, but not affected by food. Plasma levels peak 2 to 5 hours after dosing. In the liver, ranulazine undergoes rapid and extensive metabolism, mainly via the CYP 3A4 isoenzyme of the cytochrome P450. The drug has a plasma half-life of 7 hours and is excreted in the urine about 75% and the feces 25%, almost entirely as metabolites. Your adverse effects. Again, the QT prolongation. Ranolazine can cause a dose-related increase in the QT interval and may therefore increase a risk for torsades de pointes, a serious ventricular dysrhythmia. Accordingly, the drug is contraindicated for patients with a pre-existing QT prolongation and for those taking drugs that may also increase the QT interval. In addition, ranolazine is contraindicated for patients at risk for developing high levels of the drug, namely any patient with hepatic impairment or those taking drugs that inhibit CYP3A4. The issue of drug-induced QT prolongation is discussed further in Chapter 5. Elevation of blood pressure. In patients with severe renal impairment, ranolazine can raise blood pressure by about 50 milligrams of mercury. Accordingly, blood pressure should be monitored more often in patients who are taking ranolazine. It also has other adverse effects. The most common is constipation, dizziness, nausea, and headaches. So, drug interactions. Again, because of that CYP3A4 inhibitor, agents that inhibit that section can increase levels of ranolazine and can therefore increase the risk for torsades de pointes. Accordingly, moderate or strong CYP3A4 inhibitors should therefore be avoided. Among these agents are grapefruit juice, HIV protease inhibitors, macrolide antibiotics, acyl antifungal drugs, and some calcium channel blockers. Again, we'll point out the QT drugs. Drugs that prolong the QT interval, such as uquinadil or sotalol, can increase the risk for torsades de pointes in patients taking ranolazine. So, again, they should be avoided. Chapter 5 presents the comprehensive list of all drugs that prolong your QT interval. Calcium channel blockers. Most calcium channel blockers, although not amlodipine, can inhibit CYP3A4 and therefore increase levels of ranolazine. Accordingly, when use of ranolazine plus a calcium channel blocker is indicated, amlodipine is the only calcium channel blocker that should be utilized. So, its preparation, dosage, and administration. Ranolazine is formulated in extended-release tablets, both 500 and 1,000 milligrams, and should be swallowed whole with or without food, and dosing usually should start at 500 milligrams twice daily, and may be increased to the maximum dose of 1,000 milligrams twice daily. Again, the medication may be used in combination with a nitrate, beta blocker, or specifically amlodipine, the calcium channel blocker, and other drugs for angina treatment. Treatment measures, guidelines for management of chronic stable angina. In 1999, 3 organizations, the American Heart Association, the American College of Cardiology, and the American College of Physicians, the American Society of Internal Medicine, all joined forces to produce the first national guideline on the management of chronic stable angina. The 1999 guidelines were updated again in 2002 and again in 2007. Both updates are available free at circulatingahajournals.org. The following discussion reflects recommendations in these guidelines. So, the treatment of stable angina has 2 objectives. The first, again, the prevention of MI and death. The second, the reduction of cardiac ischemia and associated anginal pain. Although both goals are desirable, prevention of MI and death is clearly the more important one. If 2 treatments are equally effective at decreasing anginal pain, but only one decreases the risk for death, then the latter is preferred. So, drugs used to prevent myocardial infarction and death. We now have medical treatments that can decrease the risk for MI and death in patients who have chronic stable angina. Therapy directed at preventing MI and death is a new paradigm in the management of stable angina, and all practitioners should become familiar with it. So, the first being antiplatelet drugs. These agents decrease platelet aggregation and therefore decrease the risk for thrombus formation in coronary arteries. The most effective agent is aspirin and Plavix, or clopidogrel. In patients with stable angina, a low-dose aspirin produces a 33% decrease in the risk for adverse cardiovascular events. Benefits of Plavix seem equal to those of aspirin, although they are not as well documented. The guidelines recommend that all patients with stable angina take 75 to 162 milligrams of aspirin daily, unless there's a specific reason not to. Aspirin and Plavix and antiplatelet drugs are discussed further in Chapter 44. Your cholesterol-lowering drugs. Elevated cholesterol is a major risk factor for coronary atherosclerosis. Drugs that lower cholesterol can slow the progression of coronary artery disease, stabilizing atherosclerotic plaques, and even cause plaque regression. Therapies that reduce cholesterol are associated with a decreased mortality from coronary artery disease or coronary heart disease. For example, in patients with established CAD, taking simvastatin can decrease the risk for mortality by up to 35%. Because of the well-established benefit of cholesterol-lowering therapy, guidelines recommend that all patients with stable angina receive a cholesterol-lowering drug. The pharmacology of all cholesterol-lowering drugs is discussed in Chapter 42. An angiotensin-converting enzyme inhibitor, or ACE inhibitors. Again, there is strong evidence that in patients with CAD, ACE inhibitors greatly reduce the incidence of adverse outcomes. In the Heart Outcome Prevention Evaluation, or HOPE trial, for example, ramipril reduced the incidence of strokes, MIs, and cardiovascular death. Among one subset of patients, those with diabetes, benefits were particularly striking. Ramipril decreased the risk for stroke by 33% and MI by 22%, and cardiovascular death by 37%. In addition, ramipril reduced the risk for nephropathy, retinopathy, and other microvascular complications of diabetes. Because of these well-documented benefits, the guidelines recommended angiotensin-converting enzyme inhibitors for most patients with established coronary artery disease, and especially for those with diabetes. The pharmacology of ACE inhibitors is discussed in Chapter 36. Your anti-anginal agents, drugs used to reduce anginal pain. Again, the goal of anti-anginal therapy is to achieve complete or nearly complete elimination of anginal pain, along with the return to normal activities. This should be accomplished with a minimum of adverse drug effects. The basic strategy of anti-anginal therapy is to provide baseline protection using one or more long-term acting drug. So again, your beta blocker, your calcium channel blocker, or long-acting nitrate. Supplemented with sublingual nitroglycerin when breakthrough pain occurs. A flow plan for drug selection is shown in the following figure. As indicated, treatment is approached sequentially. Progression from one step to the next is based on the patient's response. Some patients can be treated with a single long-acting drug. Some, however, require two or three, and some require revascularization. So here's a good spot to hit pause, so you can take a look at the flow plan of the anti-anginal drug selection in patients who have chronic but stable angina. So, initial treatment consists of sublingual nitroglycerin plus a long-acting anti-anginal drug. Beta blockers are the preferred agents for baseline therapy because they can decrease mortality, especially in a patient with a prior myocardial infarction. In addition to providing prophylaxis, beta blockers suppress nitrate-induced reflex tachycardia. If a beta blocker isn't adequate, or if there are contraindications to beta blockade, a long-acting calcium channel blocker should be added or substituted. Your dihydropyridine type CCBs, so your nifedipine, lack cardiosuppressant actions and therefore are safer than beta blockers for patients with bradycardia, AV block, or heart failure. When calcium channel blocker is to be combined with a beta blocker, a dihydropyridine is preferred to verapamil or diltiazem. Again, because both of those medications can intensify the cardiosuppressant actions of the beta blocker, whereas a dihydropyridine calcium channel blocker will not. However, if a calcium channel blocker is inadequate, or if there are contraindications to a calcium channel blocker, a long-acting nitrate should be added or substituted. However, because tolerance can develop quickly, these nitrate preparations are less well suited than a beta blocker or calcium channel blocker for continuous protection. Please note that as we proceed along the drug selection flow plan, drugs are added to the regimen, resulting in treatment with 2 or more agents. The combination therapy increases our chance of having a success because the oxygen demand is decreased by multiple mechanisms. Beta blockers reduce the heart rate and contractility, calcium channel blockers reduce the afterload, and nitrates reduce the preload. In combined treatment with a beta blocker, calcium channel blocker, and long-acting nitrate fails to provide relief, coronary artery bypass graft or a CABG, surgery or percutaneous coronary intervention, a PCI, may be indicated. Note that these invasive procedures should be considered only after more conservative treatment has been tried and failed. How should we treat angina in patients who have a coexisting condition? The anti-anginal drugs employed, your nitrates, beta blockers, and calcium channel blockers, are the same ones used in patients who have angina alone. However, when selecting among these drugs, we must consider the coexisting disorder as well as the angina. For example, as noted previously, in a patient with asthma, calcium channel blockers are preferred to beta blockers because beta blockers promote bronchoconstriction, where a calcium channel blocker would not. The following table here shows more than 20 coexisting conditions and indicates which anti-anginal agent to be used, as well as which ones should be avoided. This is an outstanding spot to hit pause and definitely review. Reduction of risk factors. Treatment program should reduce anginal risk factors. Smokers should quit. Sedentary patients should get aerobic exercise. And your diabetics and hypertension or high cholesterol patients should receive appropriate therapy. So, speaking on smoking, smoking increases the risk for cardiovascular mortality by 50%. Fortunately, smoking cessation greatly decreases that risk. Accordingly, all patients who smoke should be strongly encouraged to quit. Smoking cessation is discussed further in Chapter 32. Your high cholesterol levels. Again, as noted, high cholesterol levels increase the risk of adverse cardiovascular events, and therapies that reduce cholesterol reduce that risk. All patients that have high cholesterol levels should receive a cholesterol-lowering drug. Your hypertension. High blood pressure increases the risk for cardiovascular mortality, and lowering that blood pressure reduces the risk. All patients with hypertension should receive treatment. Your blood pressure should be reduced to about 140/90, which is at this point outdated. The recommendation I think currently is 120/80. And patients with additional risk factors, diabetes, heart failure, retinopathy, The target blood pressure is 130/80. Again, this might be a little outdated. Management for hypertension is discussed, however, in Chapter 39. Diabetes. Both type 1 and type 2 diabetes increases the risk for cardiovascular mortality. Type 1 increases the risk 3 to 10 times fold, while type 2 increases it 2 to 4. Although there is a good evidence that tight glycemic control decreases the risk for cardiovascular complications of diabetes, there is little evidence to show that tight glycemic control decreases the risk for cardiovascular complications. Nonetheless, it is prudent to strive for a optimal glycemic control. Physical inactivity. Increased physical activity has multiple benefits. In patients with chronic stable angina, exercise increases exercise tolerance and the sense of well-being and decreases anginal symptoms, cholesterol levels, and objective measures of ischemia. Accordingly, the guidelines recommend that patients perform 30 to 60 minutes of moderate intensity activity 3 to 4 times a week. Such activities include walking, jogging, cycling, and aerobic exercises. Exercise by moderate to high risk patients should be medically modified and supervised. The management of variant angina. Treatment of vasospastic angina can proceed in 3 steps. For initial therapy, either a calcium channel blocker or a long-term or a long-acting nitrate is selected. If either drug alone is inadequate, then combined therapy with a calcium channel blocker plus a nitrate should be tried. If that combination fails to control symptoms, a CABG surgery may be indicated. Beta blockers are not effective in vasospastic angina. That here concludes our next chapter. So I thank you as always for listening, and I'll see you at the next one. Till then, thank you and goodbye.